already told my presentation has become irrelevant. But I'll still, because most of you are familiar with CDC Crossmatch, because I knew this will happen. So I thought I'll be the scapegoat. So, so I'll be covering this topic under these headings: why we do CDC Crossmatch, or what is the relevance of even doing now, and what are the arrays of tests we are having, what are the components of CDC Crossmatch, what's the difference between IG and IgM, IgG and IgM antibody, and what are the clinical implications, steps, interpretation, and we have few modifications to increase the sensitivity, and obviously with limitations, and why do we need controls, and what is the effect of prozone phenomenon. So always a transplant physician is having a nightmare of having an acute or even hyperacute graft rejection. So why it is happening? Because of preformed anti-HLA antibodies which will be having in the patient's serum, and this will cross-react with the HLA antigens on the donor's HLA antigen expressed on the grafted kidney. So we are trying to predict whether the patient will be having or can have a hyperacute rejection or any kind of rejection. So we have various methods to assess the sensitization, as we have already seen. We have, and it can be commonly or broadly classified as a cell-based assay and bead-based assay. Cell-based assay are CDC crossmatch and flow crossmatch, where we will be using actually we will extract the donor's lymphocyte. So that is why we call as cell-based assay, where we use donor's lymphocyte. And then we have bead-based assay, where we use artificially created or synthetically manufactured beads, latex beads, and we actually assess it by using an equipment called Luminex, which is basically a flow cytometry. So this is how the sensitivity ranges. CDC being the least sensitive, we have certain modifications to increase the sensitivity by adding a reagent called as anti-human globulin. Flow is more sensitive, as we have discussed, and the maximum sensitivity is for Luminex assays or Luminex crossmatch or Luminex based assays like single antigen bead assay or virtual crossmatch. So CDC Crossmatch was first started by Dr. Paul Terasaki, primarily intended to detect preformed antibodies in the patient's serum or body, and this will activate the complement pathway. So we are primarily trying to catch up a preformed antibody, and we can use either total lymphocytes or separated T and B lymphocytes. And how this works, if there is antibody that is present in the patient's serum, this will interact with the donor's antigen, and then complement will help to activate the complement pathway, and at the end of the complement pathway a membrane attack complex will be formed, so MAC, and this is how the cell will get lysed or the cell will get died. And once the cell get lysed, there will be hole on the cell from which the extracellular fluids will be entering into the cell and causing the cell death. So we do cell isolation by using, we have old technique which is called as density gradient method, where we use a reagent called as Ficol HiPAC, and then we have certain modifications in nowadays. We have something called as, where we use positive selection or negative selection, and we use magnetic beads for the separation. So obviously the quality will be high. Then we use a dye called as trypan blue to check the viability and adjust the concentration, because we are loading it on a Terasaki tray. So the concentration has to be at a proper, it should not be too high, it should not be too low. Then we use Terasaki tray, can be either 60 well or 72 well format. So Terasaki tray is used for dotting these isolated cell and serum, and we use specialized syringe called as Hamilton syringe, which needs a lot of skill to use it, because for each pressing we are dropping 1 microliter of serum and cell, and 1 microliter is corresponding to, if you pinpoint on a white paper with a pen, that will be equal to 1 microliter. So that needs a lot of skill, and for this we use rabbit derived complements. So various studies have been conducted, and it has found that the best outcome was obtained from complement derived from rabbit. We also use a dye called as eosin, which is actually used to enter the cell, dyed cell. So once the cell get dyed or lysed, through that hole this eosin will enter the cell, and we can see the dead cells or lysed cells as dark red color. So here you can see all these are having dark red dots, so they are lysed cells, and all those which are white with glow cells are live cells. We also use a reagent called as formalin to preserve the morphology and fix the cells, otherwise the cell morphology will get damaged. We also do auto crossmatch to know whether some auto antibodies are there, because that can mask the presence of specific HLA antibodies or allo antibodies. So here we are using both serum and cell which is derived from the same patient. So if auto cross match is positive, then we have to know whether it is IgM antibody or IgG antibody. I think Dr. Anil Handu sir has got experience of having, usually we will get IgM and auto antibody. So he was, last day we were discussing and he was having an experience of having IgG auto antibodies. So these are the steps how we do. So we'll incubate the cell and the serum and we add complement because we are incubating it all together and allowing the reaction to happen. And if anti-HLA antibodies are there, donor-specific antibodies are there, they'll get bind to each other. And we are doing all this process on Terasaki tray. We keep it on inverted phase contrast microscope and we see whether dead cells are there or not. So if dead cells are there, it will be seen as dark red colored cells, and if they are live cells, it will be white, nice cells with glow around them. And this is the grading of CDC Crossmatch. Different centers follow different grading. So generally it is like less than 10% for negative and is as shown. More than 80% it is strong positive. So we have seen that CDC is known to be less sensitive. So if the patient is having less amount of anti-HLA antibodies, there is a chance of missing or we are getting false negative. So this is a picture to show how it will be looking. So here we can see all nice round shaped with white cells with glow around it. And this is how it positive cross match will look like. So if you closely observe, you can see on each so on each cell, all bright red cell, dark red cell, you can see something like a protrusion. So that is how the cell get lysed and membrane attack works, membrane MAC complex works. So this is a range of pictures. On the left top portion, you can see a case where it is clean negative, and on right bottom portion, you can see a case where it is fully positive, full dead cells. And we have few modifications. We extend the incubation time, thereby increasing sensitivity. So normally if we are having 30 minutes incubation, we will incubate it for 1 hour. And if it is 1 hour, we will incubate it for 2 hours. So that's how we increase the sensitivity. Then we have few advancements or modifications of cell isolation. We use magnetic based, bead based methods. So we have proper quality, good quality lymphocytes. Then we, as told earlier, we use anti-human globulin to enhance the sensitivity. And we do use DTT to differentiate whether it is IgM or IgG antibody. So this is the most advanced technique where we use magnetic based or positive or negative based selection. By negative based selection, I mean we are tagging all the cells except our cell of interest, and these tagged cells will, this is the violet thing is a magnet. So we are tagging all the cells except our cell of interest, and these cells will get attracted to the magnet. So the supernatant will be having our cell of interest, which is a lymphocyte. So we do this process for 3 times. So we have seen that the quality of lymphocyte that we isolate is much better compared to the older method. And we use a reagent called as DTT to isolate, to differentiate whether it is IgG or IgM antibody. And how it works, this breaks the pentamer. It's breaking the IgM pentamer and converting into monomer so that the complement is not getting activated. So because IgM antibody is generally considered to be clinically insignificant. But the one thing is that this IgM can later get class switched to IgG antibody. So this is how we identified, because on DTT treatment, if the reaction goes, it becomes negative, then it is IgM antibody. If the reaction persists even with DTT treatment, it is IgG antibody. So as I told, the class switch has to be considered, and for this repeat cross match has to be done to know whether class switch has happened or not. And this is just to show that CDC, even though principle wise it is very easy, technique wise it is very complicated, because if just one reagent is not prepared properly, the whole cross match will get damaged. So here the DTT was not stored properly. So we got a coagulated appearance on the CDC cross match because of DTT issue. Then we have AHG, anti-human globulin, that is used for enhancing sensitivity. How it is enhancing? By multiple Ig molecules will bind to donor-specific antibodies attached to the donor cells by amplifying and thereby amplifying the total number of Fc receptors. So it's just like giving a helping hand. If the antibodies can't catch together, we are giving an extra hand to help them to catch together. Obviously, it is having a lot of limitations and challenges. CDC is known to cause false positive, false negative, and if we don't have proper technique for cell isolation, then it will affect the viability of cells. So our negative control will also be having a dead cell, which will affect our interpretation. And it is known to have low sensitivity to pick up low level of antibody. Also for class 2 antibodies, it's less sensitive to pick up class 2 antibody. And apart from this, it is very laborious and labor intensive technique which need, and the reporting is also very subjective. So historical importance of CDC in solid organ transplantation is unquestionable because it is the best test to predict hyperacute graft rejection. However, with advancement of lot of technique like flow cytometry, Luminex based assay, we have to consider whether it has outlived its usefulness and to think whether we have to embrace a new gold standard in histocompatibility testing. We do use lot of controls in CDC Crossmatch, like we have positive control, negative control, and diluent control. Each control is like a checkpoint for us because if any of the control fails, then there is some problem with the crossmatch. So first thing that we see is whether all the controls have worked. We have case discussion in afternoon session. So in that we have various cases where these controls are not working properly. Just to sum up with the prozone, there is something called as prozone phenomenon, especially seen in highly sensitized individuals, highly sensitized patient who has got previous transplants or history of multiple transfusions. So these candidates will be having lot of antibody produced in their body. So I'm just telling an analogy. If there is a classroom with one girl and 10 boys, all the 10 boys will be trying to have a relationship with that one girl. So ultimately nobody will get that chance. So if we are having 5 boys and 5 girls, automatically at the end of 1 year they will have 5 relationships. So likewise there should be a balance between antigen and antibody. So prozone is like you are having lot of antibodies and nobody is able to attach with the antigen. So in this case we have to do proper dilution and make them into an equal amount or try to strike a balance and then do the cross match. This is applicable for not only for CDC, for flow and single antigen assay also. So summing up, this is CDC Crossmatch is an excellent test to predict hyperacute graft rejection, but it is less sensitive. And you should always correlate the CDC Crossmatch with other platforms like virtual crossmatch and flow crossmatch. And prozone should be suspected in individuals with highly sensitized individuals, especially with high PRA. And for this, we have to do routine dilution studies. So always we need to compare different platforms and compare the results or correlate the results clinically. And moreover, we need a clinical correlation as well. Thank you.
Dr. Antonio, that was an excellent presentation. Thank you so much. I have only one question from my side. We were talking about the interferences by the therapeutic agents, the rituximab. So do you have any of the protocols, what has been followed in few papers by using any of the prozone, pronase or something to do with anti-rituximab?
We use pronase for flow crossmatch, but not for CDC crossmatch. Anyway, we will be collecting the history from once we get the sample from the clinician. So we'll have, even if it is not filled properly, we'll contact them and ask whether this patient is having any medications. Because in the request form itself, we are asking for all the details, whether there is any medications and if medication is there, what is the medication. So we'll be contacting clinicians and having a clinical correlation. For CDC crossmatch, we don't use pronase, but for flow crossmatch, we use pronase.
Okay, thank you.
So thank you, Antonio. Very nice presentation. Though I'm not sure you understood human relationships very well. Any questions from the audience?
That was great, Dr. Antonio. This IgG autoantibodies, is it, how common it is? Can it be a problem?
I think Anil sir can give more insights into it.
So I've had some experience on this some time ago. This was with regard to the IgG positivity, which is an auto IgG. So we've found it less than 1% of cases, but we do get it. And invariably in all of them, even the auto cross-match, we're picking it up and DTT doesn't clean it at all. Now, when we went back and tried to figure out, did this patient actually have an underlying autoimmune disorder, which could kind of explain the presence of that antibody? Out of the number of cases that we had, I don't have the exact number with me right now, but only less than 50% actually had an SLE or SLE-like disorder. So I'm not really sure what caused that antibody. In fact, I spoke to Dolly ma'am also and some other experts globally to figure out how have they catered with it. The thing is, they have just said that, if it's there, we assume that it's an autoantibody which is going to be irrelevant, or an anti-idiotypic antibody which can again be irrelevant, and therefore they would just go ahead with the transplant. And invariably, they have had good success. So that's where we stand at the moment with respect to this.
As you said, the CDC is not a very sensitive test, but what is the significance of grading? For example, we had a cadaveric donor who came to us with a percentage weekly positive that was reported in Amrita. And at that point of time, we were doubtful because we don't have time for further evaluation overnight. And this patient was bold enough to take up that risk after counseling. So how do we go about it? So my question is also to the panelists. So when you have a borderline weekly positive CDC, we already know this test is not a very sensitive test. And if it's grade positive, then you should not. But when you get a borderline positive, something like a 10 to 20% or a weekly positive, do you outrightly tell a no? Or because for a cadaveric donor, when you get the donor overnight, when you don't have time for further evaluation, how do you go about it?
Yeah, actually in CDC we have seen that even if the cross-match is negative, that patient is likely to have an antibody with an MFI of even 7,000. So we have seen even MFI of 7,000 is having a CDC negative. So which means CDC, if it is coming as weak positive, he's likely to have an MFI of antibody with MFI of even more than 7,000. So it's a clinical call how to go about it.
I think it's a difficult one to analyze. If a cadaver is showing only weak positive and the patient is actually not sensitized either way, I would probably go ahead with the transplant. But on the other hand, I have seen patients who are actually sensitized, but their cross-match comes as negative. So I'm not sure whether those patients should be taken up at all, because they had a lot of reactions and we know that there are plenty of antibodies and they come out as negative. And somehow I find some reason to reject them, because otherwise I'll end up in trouble. So now we have started doing flow cross-match generally, and that's much more sensitive. So probably that will be the way out.
Yeah, my question is Dr. T.T. Paul. Having been in the transplant field for the last 3 decades or so, how do you consider CDC cross-match alone? Or I'm sure when you started off, there was nothing else. And how was the outcome in the last, say, 30 years or so?
That's a very good question. As a matter of fact, I have been sitting here and watching all the slides, and all the new information. When I started nephrology in CMC Vellore way back in 79, 81, none of these things ever was mentioned in any textbooks. We used to transplant those patients from CMC only with cross-match. HLA typing even was done only rarely if not all patients, we just presumed since it was all supposed to be life related, so we felt that it was. And cyclosporin and Celcept were not there. It was only azathioprine and steroids, high doses. When we really think back and go back into that one, with all these advances, how much we have achieved? It's a very good question, because we have a DSA, like we mentioned, the last slide Antonio put up, is that, if the antibody level is very high, you can get a false negative. It's very paradoxical. So it is it's very, very difficult to answer that question, because I really wonder, with all this advancing knowledge, how much we have advanced. But then advancing is always very slow. And it should be never taken as an indication that we should not continue to aspire, because tomorrow somebody might come and tell that, this is the right thing and this is not exactly what we were thinking before. Several experiences are there in our field, where these things, So I feel for all the things that has been happening, I agree with your question that, how much we have really gone up into the results is very questionable. But we do have good results. In first year survival, about 90% in our center also. But DSA, we still do DSA. DSA negative, we confirm with flow this 1%. Then there are other political issues also, socio-political issue, because once it comes as positive, then it is very difficult to tell them about the theories and consider the patient for the donor for transplantation. Questions from the floor, more questions from the floor. And only you left a lot of time for questions. Okay, thank you very much. We'll close the session.